Every year in the United States, patients receive an estimated 9 million epidural steroid injections for low back pain. These procedures generate billions of dollars in healthcare expenditures. Yet, the American College of Physicians, the American Society of Anesthesiologists, and the UK's National Institute for Health and Care Excellence, known as NICE, all explicitly recommend against their routine use. Multiple randomized controlled trials and meta-analyses show that for patients with chronic, non-specific low back pain, epidural steroid injections do not meaningfully improve long-term pain or physical function. Repeated exposure to these corticosteroids carries documented risks. Patients face higher chances of systemic bone demineralization, adrenal suppression, and rare but serious procedural complications like dural punctures, a tear in the tough membrane surrounding the spinal cord. Relying on these procedures early in a treatment plan also creates a massive opportunity cost. It reinforces a passive model of care, delaying patients from engaging with active self-management strategies, like exercise therapy, that are central to long-term recovery. The scientific evidence clearly advises limiting these injections, but the fee-for-service reimbursement structure continues to drive their use at an industrial scale. There is a common assumption in medicine that publishing new evidence or updating clinical guidelines will automatically alter daily practice. Historical data shows that the median lag between widespread use of a medical procedure and the reversal of that ineffective practice is approximately 9 years. Inefficient practices do not naturally fade away. They are actively sustained by entrenched reimbursement incentives, provider training norms, and patient expectations. Removing these interventions requires a process called de-implementation. De-implementation is a purposeful, multi-stage strategy designed to reduce or stop the use of health services that are ineffective or harmful. Healthcare systems have built comprehensive processes, metrics, and funding streams to implement new treatments. They largely lack the operational mechanisms to actively retire entrenched routines. Achieving value-based care requires health systems to dismantle low-value clinical pathways with the exact same scientific rigor they use to introduce new therapies. This circular roadmap outlines a 4-step framework to dismantle a low-value pathway like spinal injections. It begins in Quadrant 1, Identify Practice. Health systems must analyze their electronic health records and claims data to quantify the exact scope of injection overuse. Analysts examine the data for specific sequencing errors. A primary indicator of low-value care is an injection occurring before a patient has even attempted conservative treatments like physical therapy. Another major red flag in the clinical sequence is authorizing the spinal injection without any prior imaging or appropriate diagnostic workup to confirm the source of the pain. Systems also track how injection rates vary across different local providers and clinics, comparing those patterns directly against published national benchmarks. Isolating these highly specific, inappropriate clinical sequences transforms a vague concept of overuse into a quantifiable metric that hospital leadership can directly target. The roadmap then moves to the second quadrant, assessing the determinants or exact friction points keeping the outdated procedure alive across 4 distinct levels. This diagram breaks down those 4 levels of resistance. At the foundational system level, fee-for-service reimbursement models reward procedural volume over time-intensive cognitive care, providing a direct financial mandate for injections. Moving up to the organizational level, hospital infrastructure is built around procedures. Default order sets in electronic health records make generating a referral for a spinal injection the path of least resistance for a busy physician. At the interpersonal level, there is a communication mismatch. Providers often authorize injections because they fear disappointing patients who arrive with strong expectations for a procedural quick fix. Finally, at the individual level, administering procedural interventions is deeply tied to a specialist's core medical training, professional identity, and habitual daily workflow. Epidural spinal injections persist across health systems because they are structurally frictionless to order, culturally expected by patients, and highly lucrative to perform. To counter this resistance, the third quadrant of the roadmap requires matching specific de-implementation strategies directly to those identified determinants. Systems can choose aggressive pathways to limit volume. This includes full removal of the procedure for nonspecific chronic pain, or restriction by altering electronic health record workflows to mandate strict prior authorization before an injection can be scheduled. Crucially, any restriction must be paired with a replacement pathway. De-implementation fails if it simply removes an option and leaves a clinical void for a patient experiencing pain. The health system must simultaneously scale up evidence-based alternatives. These include structured physical therapy, chiropractic care, and mind-body interventions like mindfulness-based stress reduction, a program that uses meditation and yoga to help patients manage chronic pain. To address the financial determinant, systems use financial alignment. Payers can create alternative bundled payments that explicitly exclude spinal injections, removing the monetary incentive to overprescribe them. At the clinic level, administrators can deploy audit and feedback. Providers receive quarterly dashboards comparing their injection referral rates directly against their peers, using data transparency to shift cultural norms. Proper strategy matching extracts a low-value procedure while guaranteeing immediate reinvestment into high-value care. The final quadrant of the life cycle measures the impact of the redesign. Evaluation cannot stop at simply celebrating a drop in overall procedure volume. Leadership must monitor for unintended consequences. As this graph demonstrates, if injection rates drop successfully, the system might lack the capacity to handle the resulting surge in physical therapy referrals, causing wait times to spike. Systems must also track equity indicators. Administrators need to ensure that rural populations or patients on Medicaid do not face disproportionate delays in care when the default procedural option is removed. By tracking procedure-related cost savings against the reinvestment in alternative services, health systems generate the exact value metrics that agencies like the Centers for Medicare and Medicaid Services require to support broader policy reform. Continuous, multivariable monitoring allows clinical leadership to reallocate resources dynamically, keeping the newly engineered care pathway viable, accessible, and safe. The transition away from established procedures often triggers fear for both patients and providers. However, de-implementation is never synonymous with the withholding of care. It is the proactive, intentional redesign of care delivery. The goal is to close the gap between what is commonly done and what is proven to deliver high-value outcomes. In the current U.S. fee-for-service environment, this complex redesign will not occur organically. Lasting transformation requires decoupling hospital revenue from raw service volume. Payment structures must instead be linked directly to population management and person-centered care models. Normalizing the active removal of outdated practices frees up the financial capital, physical space, and clinical focus required to invest in evidence-based medicine. Innovation in healthcare is measured by the new technologies we implement, but it relies equally on the systemic discipline to remove what no longer serves the patient.